Okay, please take your seats. Welcome. My name's Tony David. I'm the Vice Dean for Psychiatry. And welcome to the Paul Janssen Lecture. This lecture has been a regular feature of the academic calendar at the Institute of Psychiatry, Psychology and Neuroscience for about 20 years. The lecturers are chosen on the basis of their global eminence in the field of neuroscience with a focus on schizophrenia. And for their abilities as communicators. So the annual lecture is named in the honor of Paul Janssen, the Belgian psychopharmacologist who discovered haloperidol and many other important drugs and founded Janssen, the company. He died in 2003. So I'm delighted to introduce Tony Grace, who is our 17th Paul Janssen lecturer. He's a distinguished professor of neuroscience at the University of Pittsburgh. Tony received his PhD from Yale University, studied under Dr. Benjamin Bunny, and did his postdoctoral training in the Department of Physiology and Biophysics at New York University School of Medicine. Born and raised in Pittsburgh, he's been there more or less since about 1985, has risen through the ranks of the university to the highest tenure position in neuroscience and psychiatry at the university there. So Dr. Grace has been involved in research related to the dopamine system for over 30 years. His early work, which was done as a mere graduate student, was pioneering, and he identified and characterized the way dopamine neurons fire and identified two patterns of firing, phasic and tonic, and that was able to then explain the importance of dopamine in terms of its role in human behavior, in learning, in motivation, and how, when perturbed, it can lead to several disorders of psychiatry and neurology. His methods have become absolutely standard in the field. Dr. Grace has received several awards for his research, including in 2000 the Paul Janssen Schizophrenia Research Award, Distinguished Investigator Award from the National Alliance for Research in Schizophrenia and Depression. 2008, the Lilly Basic Scientist Award from the International College of Neuropsychopharmacology, an NIMH Merit Award, and more recently the William K. Warren Research Award for outstanding work in understanding schizophrenia, and then this year the gold medal from the Society of Biological Psychiatry for, I quote, an internationally distinguished career of outstanding research and advancing knowledge in the field of psychiatric neuroscience. Dr. Grace is also an elected fellow of the American Association for the Advancement of Science. Tony Grace's work has had substantial impact on the field and has spanned neuroscience and clinical research. His H-index is 84. His most cited paper was from 1984 in Neuroscience and was about the firing patterns of nigral dopamine neurons. It has nearly 1,200 citations and is rightly regarded as a classic. His current work involves looking at the interactions between several brain regions with known involvement in schizophrenia, but also relevance to drug abuse, depression, and Parkinson's disease. He's one of a very small, incredibly valuable group of scientists who've put their formidable skills and energy into providing a neuroscience approach to the understanding of psychiatric disorders, and psychiatry really needs people like him. Most significantly, he not only performs important basic research, but has the ability to integrate his work into testable models of relevance to the human condition. In his free time, Tony tells me that he enjoys photography, skiing, and scuba diving, and cooking. He tells me that his signature dish is halibut cooked in a walnut crust, and that it's to die for. Sounds nice. I should say that when we set up the lecture, the date and its relevance to US politics was not apparent to me at the time, many months before. So now we look across the Atlantic and consider the contradictions and extremes that exist there. The same nation which has chosen an ignorant demagogue as its leader can still lead the world in the quality of its science and scholarship. while we may despair when we contemplate the worst of modern mankind that was on display in the election, I'm pleased to say that this evening we are privileged to be in the company of the very best. Ladies and gentlemen, Professor Tony Grace.
Thank you very much for that wonderful introduction and for all of you for coming. And I wanted to say what an honor it is being here, but I know that it doesn't make any difference what I say, because any minute I'm going to wake up in my bed and realize that Hillary Clinton is president. But what I'm going to be talking about is some of the work that we've been doing looking at animal models, especially animal models of schizophrenia. Now, of course, when you talk about an animal model of a uniquely human disorder, there's always some question. Can you ever make a rat schizophrenic, or are they schizophrenic all the time? And how do we know whether they're hearing squeaks? But what we can do is look at a lot of systems that we know are involved in schizophrenia from the clinical literature, from especially the outstanding imaging literature that's been coming out of the Institute of Psychiatry, and really go back and forth between the laboratory, basic science laboratory, and the clinical research to try to come up with an understanding of what we think is going on in schizophrenia. Oh, there we go. So this is the picture of the dopaminergic system in the rat. Seems to be a delay here. This is the rat dopaminergic system stained with tyrosine hydroxylase. This is the ventral tegmental area, and this is the substantia nigra. Now, as you move up the phylogenetic scale, this ventral tegmental area starts to diminish, and it actually starts to become, go on to the dorsal aspect of the substantia nigra. So in primates and humans, you have the dorsal tier and ventral tier dopaminergic neurons that are functionally equivalent to the ventral tegmental area and the substantia nigra in the rodent. And we know that the dopaminergic system is involved in a number of disorders. It's involved in Parkinson's disease with degeneration of the ventral tier substantia nigra neurons. We know that it's involved in schizophrenia, especially the more limbic associative projection system, and also in drug abuse and depression. And here it's more the medial part that projects to reward and affect-related areas of the brain. Now, what we want to do is to study the dopaminergic system, and especially to understand what the output of the dopamine system is. But how can we determine the overall activity state in the brain of a living anesthetized rat? Well, the problem is you can certainly record from single neurons. The problem is we know that not all of the dopaminergic neurons in these areas are firing. About half of them are firing spontaneously, and they're firing at different firing rates and firing patterns, but also about half of them are not spontaneously active. And in order to get an idea of just what the output of the system is, we need to go beyond recording from single neurons. And the way we do this is to pass an electrode. Sorry, this doesn't seem to be, there we go. Pass an electrode through the dopaminergic area in a preset pattern, and basically count the number of neurons that we find active in each electrode track. And this gives us an idea of the population activity, or the proportion of neurons that are active. And the ones that are firing, we also assess their firing rate and their firing pattern. And we do this because each of these parameters are actually controlled by different circuits and have a different impact on the functionality of the system. With respect to firing pattern, dopaminergic neurons fire in two different types of pattern. One is a slow, irregular, pop-pop-pop type of firing pattern. It's more the basal state. But when an animal is exposed to a behaviorally salient stimulus, dopaminergic neurons fire bursts of action potentials. These bursts of action potentials are the rapid, phasic, and what we think is the behaviorally salient output of the dopaminergic system. Whenever a neuron burst fires, it basically alerts the brain that an important event has happened. Now, this phasic burst firing is driven by glutamatergic inputs. And one of the strongest glutamatergic inputs is from a brainstem area, the pedunculopontine tegmentum, or PPTG. This releases glutamate onto NMDA receptors and causes the firing neurons to burst fire. Now, the important point is because it works on NMDA receptors, the neurons have to be depolarized and firing in order to go to a burst firing mode. If they're hyperpolarized, there's a magnesium block of the NMDA channel and nothing happens, which means only the firing neurons go into this burst firing mode. Now, this begs the question about what regulates the number of dopaminergic neurons that are firing spontaneously. Well, this seems to be controlled by a different area, the ventral pallidum, which is the limbic ventral aspect of the globus pallidus. This is a GABAergic area that fires at rather high frequencies and bombards these neurons with GABAergic IPSPs. In fact, if you do in vivo intracellular recording, you can hear this constant rumbling of these neurons bombarded with these high amplitude inhibitory conductances. This area, we believe, holds subsets of neurons in this non-firing state. Because if we inactivate the ventral pallidum, we remove this inhibition, and they all start to fire at their normal baseline firing rate and firing pattern, driven by a pacemaker conductance, not unlike what's driving the beating of the heart. Now, what's the relevance of this tonic baseline activity, number of neurons firing? Well, what this provides is a level of amplification. So the pallidum is controlling the number of neurons firing. The pedunculopontine causes firing neurons to burst fire. Burst firing, as I mentioned, is the signal, or the behaviorally relevant rapid phasic event. But the pallidum controls the gain, or the level of amplification, because the more neurons that are firing, the bigger the signal. And we believe that this system plays a big role, especially in the psychotic symptoms of schizophrenia. Now, in order to study this, what we've used is a developmental disruption model using a mitotoxin, methylazoxymethanol acetate, or MAM. We give this to the pregnant rat during gestational day 17, which is functionally equivalent to the human second trimester, which we know is a time of risk for disruption leading to schizophrenia, such as severe influenza infections, seasonality of schizophrenic births, times of famine, and things like that. We give this to the pregnant dam at gestational day 17 and then look at the adult. Now, MAM, as I mentioned, is a DNA alkylating agent that works during this second trimester equivalent. Now, the MAM developmental model of schizophrenia shows a number of characteristics that are consistent with what we would expect for an animal model of schizophrenia. First, when we look at the anatomy, what we find is there's a thinning of the limbic cortical structures. In fact, the same limbic cortical structures that you see a thinning in human schizophrenia brains post-mortem. But when you do stereology on these areas, what you find is you're not losing massive numbers of neurons. Instead, the neurons are packed closer together. So you're getting increased cell packing density, but losing neuropil, which is again consistent with what's been reported in schizophrenia brains post-mortem. There's also a lot of behavioral consistencies as well. There's deficits in sensory gating, such as pre-pulse inhibition of startle. There's impairments in executive function, such as reversal learning and extra-dimensional shift, which is sort of the rat equivalent of the Wisconsin card sort. And also deficits with respect to some of the affective dimensions, like the negative symptoms, like latent inhibition and impairments in social interaction. We also find that they tend to be hyper-responsive to drugs that we know have a strong effect on schizophrenics. We know from studies that were done back in the 50s before ethics were invented, that if you give PCP to schizophrenia patients, you could get a marked exacerbation of the schizophrenia symptoms. And in fact, the same symptoms that the person has that they can't distinguish from a relapse. By the same token, we also see a very strong exacerbation in the MAM-treated rat with PCP. We also see a big locomotor response to amphetamine. Now, interestingly, we see this increased locomotor response in the adult, but not in the prepubertal stage, which of course is consistent with schizophrenia, where in the prepubertal stage you don't really have a dopaminergic overactivity or a dopaminergic pathology. Now, the increased amphetamine response is consistent with the role for dopamine in schizophrenia. And we know that there's a long history of dopaminergic involvement in schizophrenia. All antipsychotic drugs in use today are primarily dopamine antagonists. Even the newer classes of partial agonists are still given at doses that occupy more than 95% of the dopamine receptors and do still produce a functional blockade of most receptors. Drugs that increase dopamine release, such as amphetamine and L-Dopa, will exacerbate the positive psychotic symptoms of schizophrenia, and if given at high enough doses to normals, can actually produce things that are almost indistinguishable from a paranoid schizophrenia state. And imaging studies have shown an increase in amphetamine-induced dopamine release. Now, this are studies that I'm referring to were done by Anissa Abidarga, Mark Laroel, Ellen Breyer, and a number of others. And what they showed is that they used a radioactively labeled low-affinity dopamine antagonist, raclopride. Now, because it's low affinity, it can be displaced by endogenously released dopamine. So looking at drops in radioactive label is proportional to the amount of dopamine that's being released in the human. And what they find is that, of course, amphetamine causes dopamine release and displaces raclopride. But schizophrenia patients show a much larger release and greater raclopride displacement compared to controls. And furthermore, the amplitude of the increase is proportional to the ability of the amphetamine to worsen psychosis. So what we have is an identity between an overactive or an overstimulated dopaminergic system and at least the positive psychotic state of schizophrenia. The problem is, there's not a lot of evidence for a primary deficit in the dopaminergic system. Any changes tend to be rather minor in amplitude compared to what you would get with these drug administrations. Instead, what we think is that in the schizophrenia patient and in the MAM animal, it's likely that the dopamine system is normal, but is being dysregulated by other structures. And key among these has been the hippocampus that's gotten a lot of attention. So in the MAM model of schizophrenia, there's this hyper-responsive dopaminergic system that's at least analogous to what you see in schizophrenia patients. And current clinical data using metabolic imaging studies have shown there's hyperactivity in the hippocampus that correlates with the psychotic state. Now, what I'll be talking about here is the ventral hippocampus, which is the limbic hippocampus in the rat. Now, in human imaging studies in schizophrenia, they talk about the anterior hippocampus. But this has to do with what happens during phylogeny. In the rat, you have a dorsal ventral orientation of the hippocampus from the location and place cells down to the limbic system. But through development, as the hippocampus slides into the temporal lobe, what used to be the ventral limbic hippocampus becomes the anterior limbic hippocampus in humans. Now, is the hippocampus hyperactive in the MAM animal, as seems to be the case in imaging studies in schizophrenia? Well, if we just look at how fast neurons are firing in the ventral hippocampus, what we find are the neurons in the MAM animal are firing significantly faster. But the hippocampus is a complex structure that depends more than just on firing rate to determine its functionality. Rhythmic activity is very important for understanding how the hippocampus works. And when we look at rhythmic activity, what we find in the MAM animal is a drop of the low frequency 0 to 4 hertz rhythms that we know are important for gating information flow in other areas, but an increase in the higher frequency rhythms. So instead of getting this normal gated output, it's replaced by a so-called noise, if you will, that's overdriving the system. Now, does this impact dopaminergic neuron activity? Well, if we look at the MAM rat and look at our 3 parameters of neuron activity, the number of neurons firing, their average firing rate, and their firing pattern, what we see in the MAM animal is a doubling in the number of neurons that are firing spontaneously. Basically, every single neuron is now spontaneously active. Whereas when we look at average firing rate and firing pattern, they don't seem to be changed. Now this actually correlates with clinical studies that have been done here by Ollie House and Phil McGuire. What they did is to look at fluorodopa uptake. Now fluorodopa is a dopamine precursor that's radio-labeled and is thought to be a measure of synthesis capacity. So the more active dopaminergic terminals there are, the more fluorodopa uptake there is. So what they're seeing in schizophrenia patients and ultra-high risk individuals is a metric of increased dopaminergic terminals active that we think corresponds to the increased number of dopaminergic neurons firing that are driving those terminals. So what we think is happening is that the hippocampus, when it's hyperactive, leads to an inhibition of the nucleus accumbens ventral striatum, which then inhibits the ventral pallidum, removes this inhibition, and causes all of these neurons to start becoming active. We know that this is driven by the hippocampus because if we inactivate the ventral hippocampus, in normal rats, we don't get much of an effect. But in the MAM-treated animal, what we find is that it brings the number of dopaminergic neurons firing right back down to baseline without affecting the other parameters of dopaminergic neuron firing. So does this change in dopaminergic neuron firing translate to behavior? Well, as I mentioned, thing we see in the MAM-treated animals is that the dopaminergic the rats show a hyperresponsivity to amphetamine. And here we have an example of this, where we give amphetamine, we get an increased locomotion in the normal rat, but the same dose causes a much greater increase in locomotion in the MAM-treated animal. But if we inactivate the ventral hippocampus with TTX, something that brings dopaminergic neuron firing back to baseline, it also brings the behavioral response to amphetamine back to baseline. So therefore, we think that there's a hippocampal overdrive that leads to this increased dopamine population activity, or the number of neurons firing, that we think is the basis for the hyperresponsivity of the dopamine system in schizophrenia. Now, how does this increase in population activity affect the response of the dopamine system to behaviorally salient stimuli, such as might be occurring in the normal animal or in schizophrenia? Well, one thing that the ventral hippocampus is involved in is context dependency, or the ability to adjust a response depending on the context in which it's presented. So for example, if you're in a benign context, you're sitting at home behind locked doors in the safe neighborhood, or you're sitting in an auditorium waiting for dinner to occur, listening to someone drone on about electrophysiology, you don't expect anything exciting to happen. So the ventral hippocampus is basically keeping the dopamine system toned down, not a lot of neurons firing. Then all of a sudden you hear, let's say, a noise in the back of the room. Well, this is going to activate the pedunculopontine tegmentum to drive dopamine release. But because there aren't a lot of neurons firing, you're not going to get a big dopamine release. So you hear the noise, you'll turn around and see that somebody fell asleep and fell out of their chair, and then you turn around and start playing with your iPhone again. But let's say you're in an activating context. You're an animal out hunting, where every noise is something that you could eat or something that can eat you. You have to be very vigilant all the time. Something you don't want to, a state you don't want to be in all the time, but you want to transition to this state when it's important. In this case, the hippocampus subiculum, the ventral hippocampus, has the dopamine system toned up higher. A lot of neurons firing. Now the same noise in this activating context is going to cause the same activation of the pedunculopontine, but now cause a more massive dopamine release. But what happens in the case of the schizophrenia patient? In this case, what we think is that all of the dopaminergic neurons are active. There's no modulation based on context. This is because the hippocampus is hyperactive and overdriving the dopaminergic system. Under these conditions, any stimulus that comes in, whether it's salient or not, is going to cause a massive dopamine release, which is going to cause a strong orientation towards any stimulus that comes along. Now, this is consistent with what we know about schizophrenia patients. In a really excellent book by Ellen Sachs called The Center Cannot Hold: My Journey Through Madness, talks about her own experiences with schizophrenia. And what she says is the filter that everybody else has that tells them what's important to pay attention to and what can be ignored seems to be broken down, so that they're just flooded with things competing with attention. It also can lead to problems with interpretation of stimuli. So for example, if you look outside the window and see two complete strangers talking to each other, this is something that you would safely dismiss as not being salient or relevant to you. But to a schizophrenia patient, when they see this, their dopamine system starts screaming at their brain, this is really important for our survival. This is really salient to us. And they start to confabulate to try to explain this disconnect between what they're seeing and what they're feeling. So they come up with stories that these are aliens trying to abduct them, that this is a plot to try to infiltrate their minds. I used to say it was the NSA spying on them, but that's probably not a delusion. But what it leads to is a overinterpretation of events. So when the hippocampus is hyperactive, the dopaminergic system is hyper-responsive to stimuli and results in overinterpretation of events and the inability to focus on behaviorally salient stimuli. Something that, of course, Satish Kapoor has referred to as aberrant salience, or the improper attribution of importance to things that can be safely ignored. Now, as I mentioned, one other thing the ventral hippocampus is involved in is context dependency. And schizophrenia patients are notoriously bad at context dependency, choosing the right response for the given context. When we look at this at the MAM animals, what we do is we look at a context-dependent phenomenon where we have two different contexts that vary based on shape, based on sound, smell, and tone. We shock the animals in one context, in a fear conditioning, and then put them in another context where they haven't been exposed to these stimuli. And like all normal rats, what they show is a big increase in the response to the punished environment and no change in the normal environment. But the MAM animals don't show a difference. And in fact, this is very consistent with what's been reported in schizophrenia patients, where controls show a much higher level of rated uneasiness in the punished context compared to the neutral context, whereas the schizophrenia patients don't show a difference between the two contexts. So these data showed that in the MAM model of schizophrenia, this ventral hippocampal hyperactivity leads to a hyper-responsive dopaminergic system that we think is at least responsible for some of the psychotic symptoms. Why is the hippocampus hyperactive? Well, probably the most robust postmortem finding that's been seen in schizophrenia brains is a selective loss in a specific type of GABAergic neuron. And these are the GABAergic parvalbumin-containing neurons. These show about a 30% decrease in the hippocampus and in the prefrontal cortex in schizophrenia patients compared to controls or compared to other types of disease states. In the MAM animal, we also see the same thing. We see a drop of parvalbumin GABAergic interneurons in the medial prefrontal cortex and in the ventral hippocampus, consistent with what's been reported in schizophrenia patients. Now, the thing about parvalbumin is a calcium binding protein that a neuron only makes if it needs to make it. So these GABA neurons are always making GABA. If they're not being activated, they don't need to make parvalbumin. So the question is, are we seeing this drop because the neurons are dead or they're being underactivated? Well, in order to do this, we actually turned to the literature on temporal lobe epilepsy. And what they found is that you can stain parvalbumin neurons for substance P receptors that are always expressed. and then look at the substance P receptor expression versus parvalbumin receptor expression. And what they found is that the neurons were still there, they just weren't making parvalbumin. Well, when we look at the MAM-treated rats, what we find is that if we look prepubertally, what we find are the neurons are still there, but they're not making parvalbumin. But when you get up to the adult, you see a drop in both markers, which means the neurons are actually dead by the time you get to the adult. They're just completely gone. So in the early pre-symptomatic stage, they stop making parvalbumin. Later on, they seem to die off. Now, what I've talked about is this ventral hippocampal hyperactivity that we think drives this overactive dopaminergic system and leads to psychosis. But unlike cases where you might have a loss of function, whenever you have a hippocampus that's hyperactive and dysrhythmic, it's not only going to overdrive the dopaminergic system, it's going to affect its other postsynaptic targets. Among these are the amygdala, which through the cingulate and orbital frontal cortex is very strongly involved in emotions and can lead to negative symptoms. It also projects to the prefrontal cortex that's going to be involved in cognition. So we think this overdriven dysrhythmic hippocampus is really dragging down the whole circuit that's responsible for positive, negative, and cognitive symptoms in schizophrenia. So evidence suggests that both in schizophrenia and the MAM model, there's hyperactivity in the ventral hippocampus, possibly due to this decreased interneuron function. And if we inactivate the ventral hippocampus, we can restore normal dopamine system function. Now, how can we restore normal dopamine function in schizophrenia? Well, currently, what we do is we give antipsychotic drugs. The problem is antipsychotic drugs weren't developed to treat schizophrenia. They were actually developed to treat hay fever. They started with a compound, promazine, which is it's a phenothiazine, but it doesn't have any antidopaminergic properties. It's a prescription antihistamine. But like all antihistamines, it was very sedating. So what they did is manipulate this molecule to try to come up with something that was less sedating. And they chlorinated it, but they found out not only was it every bit as sedating, now it didn't have antihistamine properties. But a French surgeon, Labourite, found that he could actually give it to patients that were undergoing surgery and stabilize them for long periods of time. And he actually coined the term neuroleptic as a neural stabilizer. Now, Delay and Deniquet, working in Paris at a schizophrenia asylum, thought that, well, neural stabilizer, what a great drug to give to psychotic patients. So he gave it to everybody, and the schizophrenics started to get better. And this was a full 10 years before it was found that this drug actually worked to block dopamine. The problem is we now believe that in schizophrenia, there's a problem with this synapse in the hippocampus. So this, we think, is the site of deficit. The problem is we treat schizophrenia by blocking dopamine receptors here, which is 1, 2, 3, 4, 5 synapses downstream from where we think the problem is. So it's no wonder that these drugs aren't as effective and selective as we would like them to be. A better approach would be to attack it at the site of pathology. And the site of pathology, we think, is these parvalbumin interneurons. Parvalbumin interneurons are driven by NMDA receptors. And of course, this is a site where PCP acts. So if you have a case where you've already got a diminished parvalbumin system, PCP is going to make this even worse. You could try to potentiate GABA, but the problem is GABA are 30% of the synapses in the brain. And if you give a high dose of a GABA potentiating drug like a benzodiazepine, it's going to put people to sleep. Now, although they may not be psychotic, it's probably not the best therapeutic avenue. But nature actually gave us a handle on this. There are actually 6 different subtypes of GABA receptors. GABA receptors are pentameric structures, and the alpha subunit of this structure is what binds the benzodiazepine. And there are 6 different alpha subunits. Benzodiazepines tend to work on the alpha 1, alpha 2 subunit, But the hippocampus is selectively concentrated in the alpha 5 subunit that doesn't have these sedating properties. So could we potentiate GABA selectively in the hippocampus with a GABA A alpha 5 drug, which would be ideal because unlike the alpha 1 and 2 that are responsible for phasic inhibition, alpha 5 is responsible for tonic inhibition. So what we did is to work with a Jim Cook, or Captain Cook in Madison, Wisconsin, who gave us a selective GABA A alpha 5 benzodiazepine, or positive allosteric modulator. Now this drug seems to be very selective because if we look at, let's say, a evoked response within the ventral hippocampus, low doses of this drug really decrease the excitability of the ventral hippocampus. But if we look at a different excitatory synapse, like the thalamic evoked response in the cingulate cortex, even 10 times the dose of this drug has no effect. Now, what about if we try it in the MAM-treated animal? Well, in control animals, this drug doesn't seem to have much of an effect when the system is already in balance. But in the MAM case, where the hippocampus is overdriven and you've got too many dopaminergic neurons firing, this drug brings dopaminergic firing right back down to baseline, and it also brings the behavioral response to amphetamine right back down to baseline. So it seems to be restoring normal activity in the hippocampus, restoring normal dopamine system function, which might make you think, well, why aren't drug companies running out and developing compounds like this? Well, the problem is drug companies have been really burned trying to develop drugs based on animal models. Drugs like Lilly's mGluR23 agonist, Pfizer's PDE10 inhibitor, Roche's glycine reuptake inhibitor are all thought to work on this system, look good in animal models, but failed in the clinic. And they came to the conclusion that you can't translate from animal models into the clinical condition. But we came to a different conclusion. They don't know how to run clinical trials. Now, why do I say this? Well, the problem is that antipsychotic drugs, novel compounds, are tried in clinical trials on patients that have been on antipsychotic drugs for decades. They're withdrawn from the drugs for 1 week and assume the system goes all the way back to normal, and then when they try these novel compounds, they're not working. The thing is, dopamine blocking drugs alter the system. They cause dopamine supersensitivity, which means now the system's going to be over-responsive whether or not the hippocampus is driving it. We tested this in the MAM model by giving them an antipsychotic drug, a classic antipsychotic drug. So what we gave is 3 weeks of haloperidol and then withdrew them for 1 week and tested our GABAergic compound, the one that works so nicely in the MAM-treated animal, that after repeated haloperidol, it has no effect. Even inactivating the ventral hippocampus has no effect. When we look at the behavioral response, what we see is that in the MAM-treated animal, this GABA compound brings the response to amphetamine back to normal, but after haloperidol, it now no longer has an effect. So in other words, whenever you withdraw a chronic D2 antagonist, you expose supersensitive dopamine receptors. Once that occurs, the only thing that's going to work is another D2 antagonist until you bring the system back down to normal, which will take way too long compared to what you might need to do in order to get a clinical response. So what do? Well, one is to not use trials that are huge on huge numbers of population on patients, but instead target them either on early schizophrenia patients or on non-compliant patients. We can't withdraw them for longer than a week, but they do it to themselves all the time. So we could get people that are non-compliant and try some of these drugs to see if we can now get a response. So in schizophrenia in the MAM model, we think that this interneuron dysfunction is a primary drive of the symptomatology. And if we could restore interneuron function within these circuits, we think it could be an effective therapeutic strategy. The problem is schizophrenia is bad for the brain. The duration of untreated psychosis is correlated with a worse prognosis. The holy grail is really to prevent schizophrenia to begin with in at-risk individuals. Now, how can we do this? Well, one thing that's really been identified as a risk factor for schizophrenia are things related to stress. We know that stressful stimuli in schizophrenia patients will lead to an exacerbation of the positive symptoms. In studies that have been done by Eve Johnstone, Robin Murray, and others, have looked at children that were at genetic risk for schizophrenia. And what they did is do psychometric tests to see what's different about these children that are at risk. And what they found are the children that were hyper-responsive to stress tended to be the ones that converted to schizophrenia. The ones that had normal responses didn't tend to convert. And the thing about stress is stress activates the amygdala hippocampal pathway and will damage parvalbumin interneurons that we know are lost in the schizophrenia patient. The premise is in normal individuals, stress is regulated by a number of structures, especially the prefrontal cortex. But if the prefrontal cortex isn't working, what you're going to get is a cascade of events that magnifies the effects of stress and leads to this brain damage. So in the normal individual, stress leads to an activation of mesocortical dopamine systems. Dopamine is released into the medial prefrontal cortex, activates the medial prefrontal cortex, and feeds back and limits the stress response. The problem is, in a schizophrenia patient, if there's deficit in dopamine modulation of the medial prefrontal cortex or structural deficits in the prefrontal cortex, you're going to get a dysregulated dopaminergic system. You're also not going to get the prefrontal cortex down modulation of the amygdala during stressors, which means you're going to exacerbate the stress response. This is going to drive the noradrenergic locus coeruleus to an even greater extent, leading to greater stress, which is then going to increase hypothalamic and glucocorticoid responses to stress, lead to hippocampal damage, and so on in this reentrant loop, where stress magnifies the effects of stress, leading to even more stress in susceptible individuals. Now, are MAM rats more sensitive to stressors, as seems to be happening in schizophrenia patients? Well, if we look at the MAM rats pre-pubertally, before you see any changes in the dopaminergic system, what we find is that they're hyper-responsive to stress. In this case, what we're looking at is ultrasonic vocalizations. If you give a rat a foot shock, what it'll do is it'll freeze. But it's not just freezing passively, it's actually screaming ultrasonically. And if you have a microphone that's sensitive enough to detect this, you can tell this, which is why you never stress a rat in an animal room, because all the other rats are going to know it. But what we find is that this foot shock causes much higher levels of vocalization and much longer vocalization in the MAM rat compared to the control. We also know that these rats are more anxious. And this is a test called the elevated plus maze, where you have a plus runway where two arms are enclosed and two arms are open. Normal rats will explore all the arms, but the more anxious a rat is, the more it's likely to hide in the closed arm. And what we find are the MAM rats hide in the closed arm. One area of the brain that's been associated with anxiety is the amygdala. And when we look in the MAM-treated animals peripubertally, what we find is the amygdala is firing a lot faster. So every indice suggests that these animals are hyper-responsive to stress and more anxious before the symptomatology of the schizophrenia-like symptomatology occurs. Now, if stress plays a role in the developmental etiology of schizophrenia, this would suggest that we could intervene and prevent the stress. We should be able to prevent the transition. And what we did is to test this in the MAM animal by giving them the anti-anxiety agent diazepam. We did this peripubertally and then tested the animals as adults. So first we got a dose of diazepam. that normalized behavior in the elevated plus maze and brought amygdala neuron firing back to normal. We then gave this for 10 days, starting at postnatal day 31 to 40, puberty occurring about day 35 and 36 in females and about day 41 and 42 in males. We then wait until they reach adulthood and look at the consequences. First, what we find is that the diazepam blunts the loss of parvalbumin interneurons. So we're actually protecting the parvalbumin interneurons by controlling stress. We also see that in the diazepam-treated MAM rats, we don't get the activation of dopaminergic neuron firing, and we don't get the behavioral hyperresponsivity to amphetamine. So what this is saying is, from converging evidence from clinical and basic science studies, we think the inability to regulate stress early in life can lead to pathological changes in the hippocampus that we think can underlie the emergence of schizophrenia in the adult. The fact that MAM can be circumvented, we think, raises an interesting issue, because what it suggests is the MAM isn't causing schizophrenia. The MAM is causing a hyperresponsivity to stress, and the hyperresponsivity to stress is causing schizophrenia. And I'm willing to bet that a lot of the studies that are looking at genetics of schizophrenia are going to identify genes that are more involved in stress regulation than they are in what you would expect in control of the dopaminergic system. Now, what this suggests is if you actually cause major stresses in a rat right around this vulnerable time point, you should be able to get schizophrenia. And we know half of schizophrenia is not even genetically linked, but it tends to be more spurious. So what we did is to expose rats during this period that we give diazepam to MAM rats. Instead, we take normal rats, and we give them either 3 sessions of restraint for 1 hour, daily foot shock, or combined foot shock and restraint, which is really a major stressor, and then do behavior and electrophysiology when they reach adulthood. What we find is that restraint stress, when you look at them, just these 10 days of, or 3 sessions of restraint stress during this vulnerable period, when we look at them as adults, causes the rats to be more anxious. The foot shock, not so much, but combining the stressors still causes them to be very anxious. When we look at cognitive disruption, in this case we're looking at novel object recognition. How quickly can they recognize an object that's novel compared to one that they've been exposed to before? Restraint stress in this case doesn't cause a deficit in the adult, but foot shock does. And the combined stressors also cause a deficit. But when you look at the dopaminergic system, restraint stress, foot shock stress don't really change the behavior response to amphetamine. But the combined stressors given peripubertally cause a hyperlocomotion in the MAM-treated rat, or in the peripubertal stressed rats. And when you look at dopaminergic neuron firing, again, only the combined stressors lead to an activation of dopaminergic neuron firing. Interestingly, when we look at which dopaminergic neurons are affected, what we find is that it's primarily the dopaminergic neurons in the lateral VTA. Now, why is this important? Well, the lateral VTA projects to the associative striatum. And it's the associative striatum that shows the biggest amphetamine-induced dopamine release that correlates with psychosis. Now, if we try this in adults and expose them to combined stressors, now well past puberty into early adulthood, and then do our tests afterwards, what we find is that we don't see any increase in anxiety, we don't see deficits in novel object recognition, we don't see changes in locomotor response to amphetamine, and we don't see deficits with respect to dopaminergic cell activity. So the timing of the stressor is critical. It has to occur during this peripubertal period. Now, this is what's happening in normal rats. what is it about a schizophrenia patient that might make them more responsive to stress? Well, as I mentioned, stress is going to activate areas like the amygdala, which is also going to cause oxidative stress, lead to parvalbumin neuron loss, activation of ventral hippocampus, and psychosis. But one thing that mitigates the effect of stress in normals is the medial prefrontal cortex. Activating the medial prefrontal cortex drops the amygdala response to stress, which suggests if you interfere with the medial prefrontal cortex, you should get an activation of the stress response. So what we did is to lesion the medial prefrontal cortex. In this case, we did specifically the prelimbic prefrontal cortex, which is roughly equivalent to area 32 in the human. We then give them stress exposure. And in this case, we just give them foot shock, something that was ineffective at causing activation of the dopaminergic system in the adult of normal rats. And what we find is, first of all, just lesioning the prefrontal cortex makes the animals, foot shock, again, makes the animals anxious as adults. Just the lesion makes them anxious. So that's enough to increase the anxiety response. Not enough to change cognitive behavior. So medial prefrontal cortex lesions alone increase anxiety, but don't damage cognition. But with the medial prefrontal cortical lesion, now just the foot shock alone, given peripubertally, is enough to increase the activation of the dopaminergic system to amphetamine in the behavior response, and now causes activation of dopaminergic neuron firing. So when the medial prefrontal cortex isn't capable of suppressing stress responses, now more minor stressors are sufficient to lead to this pathology. Interestingly, now we get an activation of the dopaminergic system across the medial and the lateral VTA, which is actually what we see in the mam rat. So when you interfere with the prefrontal cortex and give stress, now we get both the associative and the affective components of the pathology. So therefore, the deleterious impacts of stress, combined with factors that predispose an individual to the impact of stress, we think underlie the susceptibility to schizophrenia. The increased response to stress may be mediated by a failure of the medial prefrontal cortex to limit the impact of stress exposure, which suggests that if we can identify individuals, let's say based on genetic predisposition to schizophrenia, and find the ones that are over-responding to stress, and just mitigate the effects of stress, not through diazepam, but through cognitive behavioral therapy, interaction therapy, things that you can do to humans that you can't do to a rat very effectively, we might be able to mitigate the effects of stress and prevent the transition to psychosis later in life. And then just to thank all the people who did this work, especially Holly Moore, who developed the MAM model in my lab, Yizhuan Du, who did a lot of the work on the prevention of schizophrenia, Katie Gill, who did the work looking at the GABA-A alpha 5 drug that was developed by Jim Cook, Felipe Gomez, who did all of the work that I just presented, the new stuff on peripubertal stress and prefrontal cortical lesions, Susie Sonnenschein, and who did a lot of work that I didn't get into about aripiprazole and why aripiprazole might be a drug that you can use because it doesn't cause supersensitivity as a drug that you can give to test some of these novel compounds. And thank you for your attention. I'll be happy to answer questions.
Okay, thank you for an absolutely brilliant lecture. I'm going to have a vote of thanks in a few minutes from Professor Maguire, but you've offered kindly to take some questions on the presentation. So, any questions?
Perfectly clear or perfectly confusing?
Yeah, that's right. Well, shall I start then? Can I just, I may have missed it, but the effect of haloperidol, which then, because of dopamine sensitivity, meant that the action of the particular benzodiazepine was attenuated. Is that right? So that's what's thought to explain why the clinical trials have gone wrong. But so, does your model also explain why the addition of the benzodiazepine in someone with stable haloperidol wouldn't have an augmenting effect? Because you're not, as it were, revealing the supersensitivity of the dopamine receptor.
Well, I mean, in actuality, benzodiazepine is given in conjunction with antipsychotic drugs to almost every schizophrenia patient. And we know that schizophrenia patients are very anxious, as are our MAM rats as adults. So, giving an anti-anxiety agent is going to help the drug be more effective because anxiety and stress can lead to relapse. So this is going to be something that's going to help mitigate the effects of relapse. It's not going to prevent the neuron loss because that is something we have to intervene in peripubertally. Once you get to an adult, it's too late to reverse the damage. But there are better ways of augmenting it, which means, if I had the money, I would go and buy up all these failed drugs because I would bet that they're good drugs if they're tested correctly.
Okay. Robin.
So, I mean, I think, as you know, I agree with you about the question of antipsychotics and dopamine supersensitivity. But it's not so easy to say we could find some way of testing new drugs. You would have to, as I understand it, you'd either have to give them to people who had never had antipsychotics, and therefore they would have to be very devoid of side effects, or else you would have to find people who'd only been given aripiprazole and then failed. But the trouble is that if they then fail, somebody will give them risperidone. Have you thought of some way of getting around these difficulties?
Well, I mean, one way would be to get early episode patients. And Lilly actually did a study where they fractionated their data and found that people that were in the early stages of psychosis tended to be the ones that responded to their drug better than the people that were chronic schizophrenia patients. But another is aripiprazole, because aripiprazole doesn't seem to cause supersensitivity in our hands. It doesn't seem to cause evidence of supersensitivity clinically. And one thing aripiprazole does is whenever you transition from another antipsychotic to aripiprazole, you can get an acute psychotic exacerbation. And what we find is that happens when you knock the dopaminergic neurons out of the polarization block. So what I would suggest is if you're going to do a clinical trial, transition the patients to aripiprazole.
But then they might relapse.
Temporarily. Temporarily. But if you can transition them to aripiprazole and stabilize them on aripiprazole for a period of months, you should return the system back to normal sensitivity and now be able to test these drugs. And like I said, the other is to get patients that are non-compliant, because there are patients who, after a course of antipsychotic drugs, have given them up and haven't gone back to them for months, if not years. And I've seen studies at Neurosciences where people have studied non-compliant patients that they can verify. So if we can at least identify this population, I think we'd have a better shot at getting a drug rather than taking patients that have been treated for such a long period of time with drugs that are known to alter the system.
Yeah, it's very interesting.
So functionally, PDE10 inhibitors look just like D2 receptor antagonists. Do you think there's any future for them in as antipsychotic therapy?
The which drugs?
PDE10.
PDE10. I believe so. I mean, the problem is none of these drugs have been tested well. They go by the test where you just keep increasing the population size, hoping to get a better signal. And the more you increase the population size, the more stratified the population becomes. I think they really need to do smaller targeted trials in order to get a signal. And then we need to test the Lilly compound, the Pfizer compound, the Roche compound in the appropriate human clinical models to see whether we have a signal.
I'm just interested about what is your view about other neurotransmitters like serotonin involved in psychosis? There's a lot of research going on.
Well, as you know, the selective serotonin drugs have failed in the clinic. And all the drugs that are being in use today, as Satish Kapoor and others have published, are all given at doses that occupy D2 receptors at a certain level. One thing that serotonin 5-HT2 antagonism does is it lets you give the antipsychotic drug without getting a lot of side effects. In fact, there was a compound, it's a 5-HT2A antagonist, that was shown that it can improve the response to risperidol, and it's thought to do this because it decreases the side effects. And now you can give the drug at higher doses without getting side effects. So I think as far as stabilizing other parts of the system, the serotonergic system, the alpha-adrenergic system can help to prevent some of the things that limit the ability to give the antipsychotic drugs at the doses, D2 blockers at the doses you need to get efficacy.
Thanks very much. That's a great talk. You've mentioned that the stress is very important in the origins of psychosis because it's damaging the interneurons, and that the damage is done early on. And you've mentioned it's useful symptomatically to treat anxiety in somebody who has psychosis, established psychosis. Is there any reason why treating anxiety in somebody with established psychosis would have an effect on the course, the longer-term course of the disorder?
Well, you know, like I said, we know that schizophrenia is bad for the brain, and we know that stress can lead to relapse. So certainly anything that's going to mitigate the effects of stress is going to help. I mean, stress is bad. I mean, just ask anyone in the United States right now. And stress can have these long-term consequences, and the long-term consequences depend on when they happen. I mean, what we've done is we've looked at different types of stressors in adult rats. And actually, if we look very shortly after the stress, we don't get the psychosis, but we get something that looks like depression. And we know stress in adults can lead to depression, at least for a period of time. So I think anything that mitigates the effects of stress, especially in at-risk populations or in patient populations, is going to help tremendously.
Last question, Oscar Murray.
Tony, you trace that in the defects in the MAM model all the way back to regions that control stress responses, and most specifically to the medial prefrontal cortex. Now, my question is, being MAM such and in a specific drug that, you know, at the time that you give the drug is impacting brain development in a very global way, you know, what is your explanation for such a selective impact on just precisely the medial prefrontal cortex?
I mean, that's a good question. What we know is that the MAM-treated rats are hyper-responsive to stress. And what we know is if we lesion the medial prefrontal cortex, we can get an animal that's hyper-responsive to stress. What we don't know is that MAM is working in the medial prefrontal cortex to cause the hyper-responsivity to stress. It could be working in a lot of other areas too. So MAM is a model. But the medial prefrontal cortical lesions, I think, tell us what might be happening in the human patient that makes them more susceptible to these diseases. And we haven't made the link between MAM and prefrontal cortical function. And if my grant gets funded, hopefully we'll be doing that over the next year.
Okay, thank you very much. Philip.
Okay, thanks, Tony. So I won't keep you long, you'll be pleased to hear. I just want to say a few words of thanks to Tony. So first of all, it was a fantastic talk. Thanks very much. We appreciate you being here on this difficult day. So I just wanted to say a few words about your work and your talk. I mean, one of the things I think, one of the big impacts of your work has been in terms of the way we think about the mechanisms underlying psychosis. And I think it's fair to say maybe 10 years ago, people thought of psychosis primarily as a dopamine dysfunction problem. And what you've been able to do through your work is change the thinking such that most people now, or many people now, think of it not as a primary dopamine problem, but as a problem in the cortical areas that maybe control the dopamine system. And one of the reasons I like your model is that it, as we've seen from your talk, you've been able to bring in and incorporate in a plausible way many of the other factors that we already knew from independent work were important. So the hippocampus, the impact of stressors, particularly in critical periods, the involvement of glutamate and GABA, and so on. And put these together in a kind of nice, plausible model that can be tested in humans. So it, as you know, and from what we've done here, there's quite a good correspondence between the imaging work in psychosis and what you've done in your rodent model. So I think that's been fantastically helpful. And it's also, I think, helped influence the pharmaceutical industry in thinking about novel therapeutic targets, because one of the things your novel has highlighted is the importance of fast spiking interneurons, the control of these cells by glutamatergic receptors, and the involvement, you didn't mention it in your talk, but the involvement of the cannabinoid system. And all of these have, all of that has contributed to ongoing studies looking at these non-dopaminergic kinds of intervention. So I think that's been incredibly helpful. So it's been a fantastic talk. I think the work has been incredibly influential, and I think you deserve a special bit of praise for having endured a very long day. So Tony was up all last night watching the election coverage. About 4 a.m. it dawned on him that Mr. Trump was going to be in charge, so he had to deal with that. He then had to come, he's been at the IOP all day, having his brains picked by lots of eager, enthusiastic researchers. So he's been working for a lot of time, he's jet-lagged. He's had to give this big, high-profile talk, and there's still a dinner to come. So it's been a very long day. I think he deserves a medal for managing to give such a fantastic summary of his work in this context. So thank you very much.
Just remains for me to say that you're all invited to a reception up in the Education Hub, and we'll look forward to talking to you there. Thank you very much.